Alicia, I'm so sorry, but that's okay. We have a few minutes for you to give us a nice, let's see this case.
I'll try and be quick. So,
well, just pace yourself, just let's see what we get through. It's important to teach. Go for it.
Good morning, everyone. So first of all, here's the multidisciplinary team that I would like to thank who took part to the care of the patient, who is a 76-year-old gentleman who presented to the ER with an episode described as confusion or weakness in late January. At the ER, a CT scan was performed, which showed right temporal lobe edema that was adjacent to a possible brain mass, and therefore an MRI was performed for further evaluation of the lesion that was characterized as an axial contrast enhancing mass found along the anterior aspect of the right middle cranial fossa. The patient was then referred to Dr. Quinones' team, and his past medical history is relevant for hypertension and atrial flutter that was treated with ablation and for which the patient has been put on anticoagulant medication. Overall, all the aspects of his physical examination were intact. And here we have the preoperative imaging, which was acquired on February 21st. On the left, you can see an axial T2 view, which shows a CSF cleft and the mass effect that is produced by the lesion on the surrounding brain parenchyma, making this likely an extra-axial mass, in fact. And you can see T2 hyperintensity representing the vasogenic edema that is correlated to the mass. On the right, instead, we can see an axial T1 post-GAD, which shows a homogeneously contrast enhancing mass found along the greater sphenoid bone wing. On a coronal view, so we're approaching the mass from posteriorly, it is possible to see how the mass is displacing the Sylvian fissure posteriorly, and here you can see the MCA branch that is encased by the tumor posteriorly. I also added a sagittal T1 post-GAD view so that you can appreciate in all planes the extension of the tumor, and it is possible to appreciate a draining vein along the anterior aspect of the mass. So therefore, the possible differential diagnosis for the extra-axial mass in this case can include meningioma, either typical or atypical, hemangiopericytoma, and metastasis. However, for this diagnostic hypothesis, a CT scan of the chest, of the abdomen, and of the pelvis were performed, which resulted negative, making this lesion less likely to be of metastatic origin. So given the size, the midline shift, the amount of edema, and the symptoms of the patient, surgical approach was chosen by the multidisciplinary team as the best initial approach to management. And a right frontotemporal approach for tumor resection was chosen, for which the patient was positioned supine during surgery. Importantly, the goals of the surgery was to obtain tissue for diagnosis and to perform maximal safe tumor resection. The potential risks and complications of the procedure, of which the patient and family were made aware of, are stroke, given the complex location of the tumor surrounding the MCA branches, postoperative hematoma. I think it's important to take into consideration that the patient has been on anticoagulant medication for his cardiac comorbidity for a while, seizure, infections, and CSF leak. The patient has his surgery on February 23rd, so last Thursday. If you want, for the sake of time, I can skip to the microsurgery, and if Dr. Almeida
just a second, Alicia, maybe go back a bit just so we can show the end of the craniotomy. So basically, you see this was an interfascial dissection that we did with preservation of the pericranium that will help us in the reconstruction. And then because I like to mobilize the temporalis muscle down just so we can get further exposure in the sphenoid wing. Once again, sphenoid wing meningioma is primary possibility. So we got to drill that sphenoid wing to vascularize that tumor. And a lot of this work is done in an extradural fashion as a first step. So once that's completed, you see the frontal and the temporal lobe. And the first step that Alicia is demonstrating here in the video is really going to the carotid cistern. So what you see right there is the optic nerve. So the optic nerve is right here. And I'm just opening the arachnoid of the carotid cistern to drain CSF. And then you see optic nerve and carotid is going to be here. Once we get that proximal control and relaxation of the brain, then go back ahead here to the dura and then just separate that dura a bit. And then we're not going to touch them anywhere close to the fissure as a first step. So carotid cistern, just so I know where the carotid is, drain CSF. And then after that, the next step is really to debulk the tumor towards the middle fossa. So that's what we see that we're doing there. So just going aggressively because we know there are no branches in that space. And with aggressive debulking and decompression, that tumor is going to get smaller and smaller and smaller. And then we're going to be able, after all that maneuver, to kind of start working around the vessels with a bit more space, or with not so much adherences. This is going back extradural and getting control from the feeders that will be branches of the meningoorbital and the MMA as well. And you see just removing all that tumor in close to the temporal pole. The separation here will be the periosteal layer during the lateral wall from the meningeal layer, and that we preserve the periosteal layer, of course, and we try to go. There you see some of the brain, the temporal lobe tip. And here we separate that component, and we're gonna go back to that area in the sphenoid ridge as the last part of the procedure. Anyways, now what we're gonna be doing is the debulking has been completed. So the core of the tumor has been removed. And now we're gonna peel the capsule away. So we're gonna mobilizing it away from the temporal lobe. And you see that being performed right there. And we're gonna be kind of like fishing that tumor out from bottom. As we bring this tumor to the surface, we debulk more and more. So the usual classic steps in meningioma surgery. And then this tumor is, you see, it's vascularized already. You already kind of like killed the most of the supply in that aspect. After that part was removed, what you were seeing there was just cleaning some of the area around the clinoid and preorbital fissure. But now we got to go to the MCA. And then to clean that MCA area, we got to have the proximal point, which we had in the carotid. And now we got to find the branches of the MCA trunk, so superior and inferior, to dissect and separate it. So you can see some of the branches more superficially here. And you can see them there again. And we're going to follow those branches, dissecting them. And you're going to see that one of the branches of the superior trunk of the MCA will be closely involved by the tumor, as you see it right there. So you see that we're peeling it away. And what we're trying to do now is separating this tumor in two layers. One that is going to be towards the sylvian fissure, and another one that's going to be towards the temporal, because that's going to open the window so we can connect the M1 all the way to M3 and M4. So that's what we're doing right there. And we continue peeling the tumor away. We can coagulate the small branches coming from the MCA towards the tumor, which is kind of like the same principle that we use in AVM surgery. But this one, we're gonna, of course, this is a tumor, so we're just separating it away. You can see the branches of the middle cerebral artery in close relationship, but not encased by the tumor in that aspect. But this one here was a trunk that was being encased fully by the tumor. So we decided, okay, let's get some tumor out. Let's get the big chunk of the tumor away, and then we can go back to see how much we can peel off of that vessel. Considering, of course, once again, he's 76 years old, and this pretty much looks like as a classic meningioma, but for the swelling in the brain. More importantly, so we don't want to give anybody a major stroke related with the MCA on that area. So you see the tumor core has been removed, and now we got this branch that we're going to be trying to peeling away gently from that tumor. So we start peeling it very carefully. And we got to a point, I think she's going to go back there later. And then we clean this area around the preorbital fissure. This is the clinoid, by the way. And we were able to get that area. Anyway, anyhow, this is just papaverine pledges at the end. We left a microscopic amount of tumor around that superior trunk of the MCA to avoid strokes in that area. And then we proceeded with the reconstruction. You see some hemostasis and duracibistitutes and closure. So that's it. So tell us what happened then, Alicia.
Thank you very much, Dr. Almeida.
Let me just make a couple of quick comments about a beautiful dissection that you saw JP doing. And I always go back to boxing, all right? Because in boxing, people talk, if you hit the body, if you go to the core, the head will come down. And I didn't understand what that meant when I was a little boy, and I used to watch boxing matches with my uncles who love boxing too. And that is exactly what JP was doing. He was hitting the body, and the head of this tumor just kept coming down over and over to the point that he was able to define the middle cerebral artery. And you saw that vessel, which, by the way, before we went in, we knew that he was going through the tumor. I didn't think it was going to be so intimately welded to the tumor, but we knew that it was inside the tumor. So he was already planning, and you saw how after the tumor was debulked, he was able to open the tumor like a book, track it from proximally to distally, and then go from both sides, as he was saying, separate in half. And then he had a little remnant on the other side of the artery. And then we were able to clean it up a little bit. And at the end, we left some microscopic disease against the artery and put papaveri. But it was a beautiful dissection. So I just want to make sure that people understand those principles of debulking the tumor, devascularizing the tumor, debulking the tumor, and then the tumor becomes more manageable. He was able to move away, and he put zero retraction in the brain. By the way, zero mannitol as well, especially in these patients that brain already, when you finish, you'll see how much more relaxed they are. So beautiful dissection, JP. Great work.
Thank you, boss.
Quick few comments from a radiology standpoint, Alice. I think what you did, you probably didn't realize that you did it, but in the first slide, when you described the tumor, that's exactly what you want to be doing with radiology. You close your eyes and you painted that picture. First thing that I want to hear is exactly that: intraaxial versus extraaxial. And you said extraaxial, boom. You've narrowed the differential automatically, right? You showed the nice CSF cleft, another point that tells you that this is extraaxial. By the time you got to the images, I really didn't need them. You did the description so beautifully on that first slide. Our job in radiology is to keep everyone out of trouble, right? Keep the surgeons out of trouble, keep the radiation oncologists out of trouble, keep the patients safe. And that's exactly what you did too, right? And the way that I do this is, take a look at the entire tumor and say, anteriorly it abuts this area. Medially, it's right at the level of the anterior clinoid. Posteriorly, it extends here. Laterally, it does, this. And then you can say within the central part, this encases the MCA, and then give a description. Say, is it narrowed? Is it not? Right? Because if I say it's narrowed, I know that, you guys know that if I say it's narrow, that means this tumor is going to be like closely abutted. Be careful. This thing might be adhesed to the vessel rather than just, peeling it off very, very, very quickly. What else? The other thing that narrows the differential from a radiology standpoint is that, take a look at the bone. So oftentimes it's helpful to see the CT scan. If that bone is hyperostotic, if it's thickened, that leads towards the meningioma as well. Calcifications within the tumor are helpful as well. So we tend to go with the MRI because it's the sort of the workhorse, and it's the images are prettier. But I think if you use CT and MRI in conjunction, that helps as well. Obviously, if the bone was destroyed, eroded, or irregular, that would make you worry about metastatic disease as well. And so then you're going to look a little bit closer in the rest of the body. But again, you did a great job with the radiology description. So thank you.
Thank you very much for your valuable input, Dr. Bat. I'm going to jump real quickly to the results of pathology that was given us by Dr. Janhoff, very kindly, who recorded, even though he couldn't be here.
Therefore, the diagnosis at the end of the day was a meningioma CNS WHO grade 1. We only had 2 mitoses per 10 high power fields, and we had no brain invasion. Therefore, there were no morphologic features to suggest a higher grade tumor.
So postoperatively, the patient suffered 2 complications, the first one being a generalized tonic-clonic seizure shortly after his arrival to the ICU. Here you can see the CT scan that was acquired on the next day of the seizure, which is unremarkable except for the expected surgical changes. And another CT scan was acquired early on Saturday morning, showing the formation of an epidural hematoma that you can see right here. Another CT scan was performed 6 hours later than the central one that you are seeing here, showing an enlargement of the hematoma size and of the midline shift. Therefore, the team decided that it would be appropriate to perform surgical evacuation of the hematoma. And lastly, on your right, you have the CT scan that was acquired after the surgery. The patient tolerated well the procedure and didn't suffer any issues nor complications. So the patient is still currently in the ICU where he's being closely followed, and he continues to show neurological improvement and doesn't show any focal neurological deficits. So given the results of the histology, would anyone like to comment on what you would consider to be the appropriate follow-up for this patient?
Well, it was a grade 1, right, you said?
Yes, it was a grade 1.
Oh yeah, we're gonna get an MRI, like probably as an outpatient, because I don't want him to have any problems with aspiration pneumonia, and then we're gonna do another one in 3 months, and then gonna go from there, probably like 6 months, then 1 year, and then yearly MRIs, just to make sure everything is good, considering that small residue around that vessel. And as Alicia was showing, like the patient had an immediate post-op CT scan done, as I was very concerned about strokes or vasospasm or something like that, because he was not moving the left side right after surgery. It was extubated, but not moving the left side. And then we got actually Dr. Rabi Talk and Samir, helped us review the CT angio, and we even did a CT perfusion. There were no signs of strokes or major vessel occlusion. And then the patient was brought back to the ICU. Once the patient got in the ICU, then he had an actual generalized seizure. And then, of course, we got concerned. He was intubated again. And then he got a next scan, the one that she showed 6 hours later in February 24th, that then showed that big subgaleal collection. So our impression is that those vessels open up after the seizure, previous history of aliquis, and then that blood, extravasated into the epidural space, despite our best efforts. With the patient declining neurologically, then I think it's a no-brainer. You should just go and clean up everything, and that's what we did on Saturday, so the day after the surgery. And thankfully, so the patient is recovering now, and hopefully, I'm gonna keep him the weekend, but hopefully to leave on Monday.
Thank you, Dr. Almeida. So very briefly, finally, I just wanted to share with you the results of a study that was run at the neurosurgery department at UCSF and was published 2 years ago. So the cohort includes 100 patients who are over 75 years old, which is like the case of our patient, that underwent surgical resection for meningioma, and they analyzed the complications that these patients suffered. So you can see that 30% of these patients suffered a complication, and that actually preoperative cardiovascular comorbidities and male sex were significantly associated with postoperative complications in the study. And actually, the study identified cardiovascular comorbidities to be the most important risk factors for postoperative complications. And so their conclusions were that preoperative risk assessment and medical optimization should be performed for all elderly patients undergoing meningioma resection. Thank you very much.
Thank you, everybody. Lisa, great presentation. I want to thank Gianna, who I know worked with you on this throughout the week, and Diogo, what's happening on Monday?
Yep, so Monday we're going to have our traditional BNS oral examination. It will be Gaetano, and the presenter will be Samir Kashiev, Dr. Kashiev. Then we're going to have our traditional chairman updates, and after that, the keynote speaker will be Dr. Awad, who's going to be talking to us about the advancements in endovascular management of cerebral aneurysm. So please join us Monday. Thank you, everyone, for joining us today.
Sure. Thank you, everybody. Thank you, Alice. Thank you, Andres. And looking forward to see the presentation, Dr. Walla. And have a good weekend, everybody. Thanks for joining us today. Bye-bye.
Bye. Thank you.